I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
Welcome to this episode of IDD Health Matters. We have a very exciting guest today, Dr. Beau Ances. Welcome, Dr. Ances.
It's great to be here today.
Tell us what you do in this field.
I'm an adult neurologist who sees adults with Down syndrome and specifically looking for if they're developing Alzheimer's disease.
So Alzheimer's disease, we know, affects people with Down syndrome earlier than others. Can you tell us a little bit about how it affects people with Downs in particular?
Sure. So in Down syndrome, there are 3 copies of chromosome 21. And on that chromosome is something called amyloid precursor. So it's this protein that we all have. But in Down syndrome, they make too much of this protein. And because of that, that's one of the hallmarks of Alzheimer's disease. Most individuals who get to be older with Down syndrome will develop Alzheimer's disease. The important thing is that they're developing at a much younger age compared to the general population.
So what would be some of the earlier signs that you might see in a person with Down syndrome who is beginning to show signs of Alzheimer's?
So it's a really good question. So they may have some social withdrawal. They may have some forgetfulness. So there were those activities that they used to be able to do that they were really good at. Maybe it was bowling, maybe it was coloring, maybe it was doing other activities, and they're no longer able to do some of those kinds of things. There may also be sleep changes. There may be more falls. There may be actually also seizures that may start to be seen. And so those are all signs that we're starting to get worried that something is changing within their brain.
Now, are seizures typically something you see early on, or is that something you see later?
Yeah, so seizures you see very early on in life in children with Down syndrome. Then there's a long period of time where there's not a lot of seizures. And then when individuals have significant cognitive impairment or dementia, then you may start seeing seizures again.
So you see, just to make sure I understood that correctly, you said seizures early on in life with Down syndrome, but then they lessen?
Yes.
Okay.
They may get treated, they may be on medications, they may be relatively well controlled. And then there may be seizures again in a second population where it is they never had seizures in the past, but now because there's so much shrinkage of the brain that those areas are now not talking as well, and now they develop seizures.
So when we're thinking about Alzheimer's and people with Downs, and we know that some people with Down syndrome and other intellectual and developmental disabilities may have some difficulty in using words to communicate. And some of these tests that we do, or word-based tests, or trying to look at a person in the way that their cognitive skills are, and that may already be at a different level from baseline. So how do we recognize some of these changes? You mentioned earlier about some of the skills, but in my experiences, we've seen people that their baseline is all different levels of skills, right? So how can we tease that out sometimes?
That's a really good question, a really tough question that we're often faced with, is because there's often this low level. Instead of a ceiling, there's kind of a basement. And how are individuals at different levels, and how do we evaluate them? In some individuals, that's why we use what are they typically doing, what are typical things that they're doing, and seeing if it's a change from their baseline.
So that baseline is the key, and knowing that baseline.
Absolutely. And then getting an evaluation and knowing what that baseline is, and then seeing, is it the same? Is it dropping, or is it actually increasing? Because if it's staying the same or subtly going up and down, that's one thing. That's just saying that there are good days and bad days. But if there is this baseline and it's going down and continuing to go down, that's something that's really telling us, oh, we got to really look at this, because as we were talking about even before, in Down syndrome, it's a much more sped up process. So at a younger age, and then when they do develop cognitive changes, they almost kind of fall off the cliff. And it's a really sudden changes that are occurring.
So people with Downs get it earlier.
Yes.
They're much more likely to get it than people without
Almost all will develop it, and if they live long enough, they will.
And it's a shortened time span.
And it's a shortened or accelerated time span, so it's a much more compact time span for it.
Wow. That's a lot to think about if you have Downs or if you have family members who have Down syndrome.
Right, and that's why we need to have the caregivers really evaluating those individuals, seeing what they're doing. And I talk to not just only the patient or the participant if they're in a study, it's just as important to have those caregivers, if it's either a family friend or if they're at a specific place where we really get to know what's happening with them. And so I'll give you an example of that. Yes. So a great example is I have one patient that I follow, and I'm watching, and her family said she loves to draw and she loves to color. And they followed all of her colorings and they dated every year of her colorings. And in the beginning, you could see all these beautiful colors, all these kinds of things, very intricate kinds of details that were going on in the patient. Then after a number of years, you saw less colors. Then you saw one color. Then you saw coloring outside of the lines. You could see the progression of the disease just in those colorings alone.
Wow, that's really, really interesting and fascinating. And I guess things like skills that people normally do, say if they can normally dress themselves, but then that starts to change, or maybe they pick out clothing that's
or they wear the same clothing and they forget to do this, or they keep on using the same clothing, or they used to sign their name, now they can't sign their name. Any of those kinds of things. They used to do bowling and now they can't figure out how to put their fingers into the bowling ball, and they can't do this kinds of stuff. Those are kinds of things where knowing that baseline for that individual, irregardless, gives us a real clue of what the trajectory is, irregardless of the testing that sometimes they may or may not be able to do.
That's one of the things I talk about a lot is knowing the baseline of the person that you're providing support for. If you're a family member, of course, you usually do know the baseline, but sometimes people who are receiving supports and services from in a residential setting, for instance, they may have staff that may not know them that well, and it can be even more of a challenge to see if there are changes that are occurring. So it's so important to know the baseline for a lot of different reasons. One, for Alzheimer's, but also just to see a change in a person that could be due to, say, an underlying medical condition that might be brewing or some sort of pain. And if you see a change in that person's behavior or other activities, it can clue you in that, hey, this person needs an evaluation.
Absolutely. And really, I also encourage families, and even we're talking today, get a baseline in the 30s, get a baseline in the 20s or 30s, so we know what they're lying at, and then we can kind of follow that individual. So setting that early is very important, because then that allows you to say, well, no, they've always looked like that, or, ooh, 5 years ago they used to do this and now they can't. That's something that I'm worried about.
So we're here at the Association on Aging with Developmental Disabilities Conference in St. Charles, Missouri, and you just gave a talk about this. And one of the things that was pretty interesting that there were a lot of things that you said that were quite interesting, to be frank. And I want to touch on some of those briefly, but one of them in particular is that we know that there's some work or some progress being made in terms of being able to diagnose Alzheimer's, and that's for everyone, not just in people with Down syndrome. You want to just briefly talk about those?
Sure. So this is really heady times. This is really exciting times, because even in medical school, a lot of these tests were never present, and now they are finally coming to fruition. We're now starting to really see that we can make a diagnosis. So there are 3 ways now we can make a diagnosis of Alzheimer's disease in an individual who may not have any changes, meaning they're on a pathway to developing Alzheimer's disease. That does not mean they have it. They're just on that pathway to develop it. One way is through pictures of the brain. So something called a PET image, where we inject a small substance into the veins. We wait a period of time and see if it's taken up by the brain. If it is, or it lights up, it tells us in vivo, meaning in a living person, there are already changes. A second way, and a very safe procedure, is to do something called a spinal tap or a lumbar puncture.
That sounds scary.
It sounds scary.
But
and
I've done them myself.
You've done them, and I've done hundreds of them. It's a very safe procedure. So we go well below where the spinal cord ends, well below where any of the nerves are, and we insert a really small needle, And it's just like it would be if you were to have an epidural, if you were going to have a kid, that it's just a little bit more, and we take some of the fluid. And what I tell people is like, we're archaeologists. We're looking at the trash of the brain, and we're trying to see if there's more of these certain hallmarks, this amyloid or tau, that are in these individuals. And it's a very safe procedure. It's also covered by CMS, so it's covered by Medicare and Medicaid. So it can be easily done and sent off. The third test, which is the most exciting, is that there are now going to be blood studies. So a simple blood study for looking at these hallmarks of amyloid and tau can now be done. It's not yet commercially available. It's done by some companies actually here in St. Louis, but it will be more available. And I expect that in the future, more people are going to have this as a screening test to see if they rule in or rule out, and then if they need further evaluation.
So that's exciting that you'll actually be able to get a diagnosis with a simple blood test.
Yes.
Do you have a timeline on when you think that might?
Next 3 to 5 years at most.
Okay. All right.
Probably even less.
All right. So the other thing that seems to be evolving are treatments. There are some medicines that we know that have been out for a while that have had, well, maybe not some benefit, but there's a new group of medicines. You mentioned that the amyloid and tau and those proteins that kind of collect in the brain, and that seems to be what the real problem is. When these medicines are really kind of targeting those and helping those to be removed from the body or removed from the brain.
Right.
And those are showing some promise.
Yes. So if you had asked me these same questions about a year ago, I would have said for the last 18 years, we have not had a new therapy that is out there for Alzheimer's disease. In the last year, there have been 2 new drugs that are going to be approved, with a third on the way. They're all monoclonal antibodies. So this MAB that you can kind of see when you're
at the end of the big long
words on
yeah.
any of the commercials that you're watching.
Ends with MAB.
It means monoclonal antibody. You got it.
Drug.
And it may be an Alzheimer. It could be other things too. And so there are 3 drugs. So there was one drug that had questionable results, and you may have seen this in the New York Times. A second drug that works very similar led to significant reduction in cognitive changes, meaning that there was still loss of some skills, but it was more gradual with the drug compared to the placebo or the sugar pill.
And that could mean a longer time that a person is able to participate in life.
You got it. And do things.
The small things.
Do the small things, interact with their kids, do the things that they like to do. It is not the C word. It's not the cure word.
Right.
It is prolonging stuff for a more slower, or more gradual decline. And so these drugs really work on that amyloid, not what the other drugs in the past, which have really been ways for 2 brain cells to talk to each other. There's a third drug that just got very favorable results, and that came out only a couple of weeks ago, and that also looks promising. However, they've also seen that, one other point is they've seen that the amyloid is significantly reduced in the brain. However, there's no free lunch. And the real big thing is that there are small chances of bleeds as well as edema or fluid in the brain.
We're talking brain bleeds.
We're talking brain bleeds. Pretty significant.
Yeah.
So that's why we have to do pictures of the brain. That's why we have to follow those individuals very carefully. And they get these injections either every 2 or 4 weeks.
That was the other thing. It's an injection. It's not like you just take a pill to get these medicines, right?
Not there yet.
You have to go to a
Not
clinic,
there.
I guess, and have
You have to
IV
go to an infusion center. You have to go to an infusion center every 2 or 4 weeks.
And is that forever? Every 2 or 4 weeks?
Great question. So on the first drug, we don't know. On the second drug, as of how it's written right now, we don't know when to stop that medication. The third drug that just had the most recent, once your amyloid's below a certain level, they actually stop the drug. And then they watch, and then they see if it's coming back up, and then we kind of give you the medication again. It's kind of almost like a whack-a-mole kind of business that's going on.
So, but a little bit more scientific.
More scientifically, yes.
So it sounds like there are very promising things on the horizon. There we definitely need some more studies.
Absolutely.
And figuring out how to use them in the best way. And speaking of studies, You are
So just to go on that other point,
yeah.
the issue is, though, all of the drugs that we just talked about that are new anti-amyloid agents have not been studied in individuals with Down syndrome. And that population is at very high risk. They've been actually excluded. And so we really need to do these specific clinical trials in adults with Down syndrome. The idea being, if they work there, they will probably work also in late onset Alzheimer's disease. So understanding what's happening in Down syndrome has not just ramifications for any individual with Down syndrome, but also for the general population.
So what's happening in terms of studies related to Down syndrome? I think you're...
Yeah, so
you're
we
on
are.
the
There are.
forefront of
There
that,
are.
aren't you?
We're very fortunate. There are studies both in the United States and in the UK where we're actually following individuals, and so we're taking those pictures of the brain.
Mm-hmm.
We're doing those PET studies. We're doing the blood studies. We're even doing, if they want, to have a spinal tap, and we're following individuals every 16 months, with the idea being that we can categorize and say, where are you on this spectrum? Are you stable? Are you on the preclinical, meaning you're already starting to have these amyloid changes, but you're stable? Or are you impaired? And we are then looking at those individuals to get them trial ready, because at the end of this year, beginning of next year, we're actually going to do a clinical trial specifically in adults with Down syndrome.
So if people are interested in at least finding out more information about the trial, if not participating in it, how can they reach you?
So they can. So the trial is called the Alzheimer's Biomarker Consortium for Down Syndrome, ABCDS. We always love those acronyms.
There's so many acronyms. Oh my gosh.
So you can look at that, and if you typed in ABCDS into your browser, you'll quickly, or Alzheimer's Biomarker Consortium for Down Syndrome, you'd see that. In St. Louis, we're here at Washington University. We are running those studies. You can easily contact us here. You can come to our lab webpage. You'll see all of that on there. You'll also see all the other sites that are also doing this. So there are some sites in the Midwest, a site or two in the West Coast, a couple sites in the East Coast, and then there's one in England. So there's really opportunities for people if they want to be in those studies. And then we also have studies here where if you don't want to do that kind of study, but you still want to do research, you can be involved. So we'll take blood. We'll even look at people's stool, so their poop, because we think that there are changes that are occurring there.
We've talked about poop on this show
And
before.
there you go.
How important it can be.
And so we're actually doing that too, so that any individual, if they really want to be 18 on up, if they either want to be in this study or they don't want to be in a study or even in a clinical trial, but they still want to be involved in research, we have something for them. All the way to the end, when we talked about a little bit about this today, is that even if an individual were to pass who has Down syndrome, we would love to study their brains. And so really to understand, because we don't have enough information and data. And so we are one of those sites, and we would love to see patients. And if they need to be seen clinically or if they want to be in research, we're open, and we'd really love to see you here.
Well, this is really exciting. Alzheimer's affects so many people, not just the person who has it, but all of their family members and supporters around them. It's a tough disease to deal with, and it's great that there are some positive things on the horizon, and the work that you're doing sounds exciting as well too. So this is great. I can't wait to hear more about it. Now, I've got one thing I'm going to ask you that we do on the show. I call it 3 in 3. So it's 3 things in 3 minutes that you would like to tell the listeners and viewers about anything you think that could improve health, wellness, the field of supports and services for people with disabilities, whatever it is. Three tips or tricks or words of wisdom.
Sure. So we covered some of these points, but it's really, really important. So number one, any individual who gets old enough with Down syndrome has a very high risk of developing Alzheimer's disease. Almost all of them will eventually develop Alzheimer's disease. So you really need to be looking out, working with the caregivers, working with individuals who know them, tracing and following this, and then set up schedules for them. So point number one is there's a high risk of developing Alzheimer's disease. How can we try to stave it off, get them involved in activities, get them have routines, make sure that they are engaging with others in either music, either dance or art or whatever that they like to do. Bowling, we have lots of that are loved by a lot of my patients. So number one, get them into those routines, because if you start seeing those changes or they're not showing up for those routines, that tells you something.
Plus, the routines sound pretty fun.
The routines are fun, and they're really engaging and socially engaging, which is very, very important. Number two, we have tests that are available, and you talked about this, and we now have the ability to make a diagnosis very early on, well before an individual even has those symptoms. And so there are blood tests, there are spinal taps, or lumbar punctures if they want to do that, or pictures of the brain. We can now start to make a diagnosis, which we never had even 5 years ago or 10 years ago. And we can really stage individuals. And because of that, step number three, we now are going to have treatments, and we are going to be able to offer people really, really important therapies. And it's not just going to, as you said, not just influence them, it'll influence family members. And we're actually even looking at the parents, because they may be at increased risk. So this is a whole team project for doing this. And only by this way are we really going to really start to make a dent, because right now, the limiting factor for us for reaching even older ages with Down syndrome is Alzheimer's disease. So the average age of life expectancy is about 58. We should want to try to improve it to 60s or 70s and give these individuals all those opportunities to enjoy life. And so we really have some really hope on the horizon.
It's wonderful to end on such a positive note. Dr. Ances, thank you for being on the show today. But more importantly, thank you for the work that you're doing in this field that is touching the lives of so many and will continue to do so. I can't wait to hear updates in the future.
Thank you for having me. It's great to be here.